welcome everyone to the National Dialogues on Behavioral Health Conference, Session 1, Building on Past Successes and Lessons from the Pandemic. My name is Jessica Flick, and I'd like to introduce your host for today, Vijay Ganju. He's the president of the National Dialogues on Behavioral Health.
Well, thank you, Jessica, and hello, everyone. As Jessica said, I'm the current president of the National Dialogues on Behavioral Health, and on behalf of our executive committee, it's a real pleasure to welcome you all to the 62nd conference of the National Dialogues on Behavioral Health. Jessica, I think we can start the slideshow. So, as Jessica said, this year's conference is titled Behavioral Health in the 21st Century, Fast Forward After the Pandemic. Well, the pandemic is still with us. Not what we had expected. We thought that the pandemic would be waning at this point and that we would be embarking on new directions. And so one thought was that in some ways we need to rename the conference. It's Behavioral Health in the 21st Century, Fast Forward After the Conference. And so, the theme of the conference is actually quite simple. A lot of good things were happening in the behavioral health world before COVID hit. And then during COVID, there were a lot of lessons that were learned, often on a very fast track. And the thought was both those strands are going to, in a way, shape the future, and we need to start preparing ourselves for that particular future. And so that's really what the focus of the entire conference is on, although we're taking different looks and angles and perspectives of how we address this future. So I think, Jessica, the next slide, please. So, what I'm going to be doing is just providing a relatively quick overview of National Dialogues on Behavioral Health, the organization, and then turn it over to Brian Hepburn, the Executive Director of the National Association of State Mental Health Program Directors, who will be moderating the section. He'll be introducing the speakers, and then we'll be managing the question and answer session. So just for those of you who don't know, the National Dialogues on Behavioral Health is the oldest continuous running conference in behavioral health in the United States. This is the 62nd year of the conference. And, it is, and I don't mean this self-serving or anything, but it is a unique conference, primarily because it is of its intimate nature and the focus on discussion and dialogue. And we really emphasize implementation on how to do things and how to get things done. And so I think another very unique aspect of the conference is that we have a very diverse set of participants. And sometimes it varies from conference to conference, but we generally have a lot of consumers, family members, advocates, service providers, policymakers. We have people from managed care organizations. And so it really does result in a sort of seeing all the different parts of the elephant in a way as we go forward. And the other thing that's pretty unique about National Dialogues is that we are 100% voluntary organization. No one working on the executive committee gets paid by the organization itself. And so in many ways, as somebody said in one of the evaluations that we received in the past, it is a jewel of a behavioral health conference. And so one of the things that we encourage is for all of you that are attending please get the word out. Please get this to your friends, colleagues, and other people who you think are interested in participating in this session, or even, well, we're going to have 5 more sessions over the next several weeks. And so really encourage you to get the word out about this. So Jessica, the next slide, please. And so I'm not going to dwell on this, but this just shows you that we do have a typo on the top. It's behavioral health, but that's my fault. But it just shows you the range of topics that we've covered in the last 5 or 6 years. But we've looked at resilience, we've looked at the criminalization of persons with mental illness, looking at the issue of value and outcomes and how you reinvent the behavioral health workforce. Last year, we had a very exciting conference on looking at crisis response at both state and local levels. And then, as I tried to indicate in the previous slide, but now, Jessica, if you can go to the next slide, please. We also, when we have our in-person conference in New Orleans, which is the general sort of way we have the conference, is that we also have a pre-conference, and this just shows you the range of topics that we've covered in the pre-conferences: school mental health, artificial intelligence, and how that's been used in terms of augmenting the behavioral health workforce, and then, behavioral health care, and again, the issue of mindfulness and how one can essentially capitalize on some of the learnings from alternative medicine. Next slide, please. And so just to give you a sense of who we have on the executive committee, actually most of the people have been very long serving, but we have people from different states. And so, we've got, and I'll just quickly read their names. James Dunaway, who's treasurer with Jackie Fleming, Deb Westfold, who serves as secretary, and then Hillary Hamlin, Megan Haupt, Brian Hepburn, Jan Krasovsky, Deborah Kupfer, Ron Manderscheid, Melanie Norwood, Stephen Philippi, and Mary Smith. And really the entire conference is really the result of the work of all the people on this executive committee. Next slide, please. And so the other thing that the National Dialogues on Behavioral Health has is that we have partnerships with several national organizations, and they not only work in collaboration, but have also been conduits to their members in participating. And this includes Ron Manderscheid with the National Association of County Behavioral Health and Development Disability Directors, WICHE, the Western Interstate Commission of Higher Education, and Deb Kupfer on our executive committee represents WICHE. And then the National Association of State Mental Health Program Directors, and Brian Hepburn and Megan are the representatives from that organization. So this whole set of collaborative relationships that results in what happens at the conference as well. Next slide, please. And the other sort of aspect of this is that we do have some conference sponsors, and they really do support some of the expenses that we incur. And right this year, we have Access Health Louisiana, Benchmark Human Services, and Genoa Healthcare. And again, a lot of appreciation and thanks to these organizations for the support that they've provided. Next slide, please. And so just quick, a few housekeeping instructions. I think we will be having, as Brian will indicate, the presentations to lead off, but then we'll have an extensive Q&A opportunity. And so please use the Q&A box at the bottom to ask questions and make comments. If you can include your name and your state, that would be helpful. In a moment, I'll talk more about CEUs. Closed captioning is available, and what you need to do is turn on the subtitle slide at the bottom for you to be able to get there. And one of the things I'm going to underline, emphasize, insist is please complete the online evaluation. There will be a Survey Monkey link that will you can access at the end of the session. You can either paste it into your browser, but the way Jessica has set it up, that there will be a screen that will be coming on after the webinar is over. And if you just click on that screen, it'll take you directly to the Survey Monkey evaluation. And it'll take you 5 minutes or less to complete that evaluation. Next slide, please. And then if you haven't already done so, because we did send you the information in a letter you should have received, but if you're interested in getting CEUs, please send an email to Melanie Norwood at the address that's highlighted, melnor64@yahoo.com. And if you just say NDBHCU request, then she will essentially send you the CEU evaluation form. And just for people to note, the CEU evaluation is different from the evaluation that I just mentioned in the last slide. At the end of the webinar, we will be providing you a unique code word, and you will need to provide that with your CEU evaluation form when you return. And yes, I think there's a question from someone whether the slides will be available to participants. Not only the slides will be available on the National Dialogues on Behavioral Health website, but the entire recording of this session and the other sessions will also be available on the website. And so, next slide, please. And so that is the URL for the website. If you want to note that, you can. But you will also see this again. You should have also got this in the letter that you received. Once again, thank you for being here. And I hope you have an exciting time at this session and the others that follow. And with that, I'm going to turn this over to Brian Hepburn, who will be moderating this session.
Thank you, Vijay, and welcome to our panelists. Welcome to the participants in the virtual audience. Yes, it's much nicer to all meet in New Orleans, and hopefully next year we'll be able to do that. But right now, we're very happy that you're able to participate. And as Vijay said, please, if you have questions as we go along, put them in the question and answer. We really want to have this interactive. And that's one of the nice things about the National Dialogues of Behavioral Health, that we're able to have more time for question and answer and make it more interactive. So with that, welcome to the Thursday, September 30th, first session. It's on building on past successes and lessons from the pandemic. This session will provide an overview of behavioral health system trajectories prior to the pandemic and how these will be melded with recent lessons learned to chart the future direction of behavioral health systems. Prior to the pandemic, there were innovations that were occurring in behavioral health. Crisis services, integration with physical health, telehealth, peer and recovery services, and school-based services, just to name a few. During the pandemic, behavioral health providers learned to adapt with urgency and success. As one observer put it, as a result of the pandemic, systems did in a few months what otherwise would have taken decades. This session will cover these different strands, how they may come together and define future models and programs. Our presenters today include Dr. Anita Everett. Dr. Everett is the director of the Center for Mental Health Services. Kirsten Beronio, the director of Policy and Regulatory Affairs for the National Association of Behavioral Healthcare. Dr. Dan Fisher, president of the National Coalition for Mental Health Recovery. Unfortunately, Dr. Josh Morgenstein will not be able to participate today. He is the assistant director at the Center for the Study of Traumatic Stress. He had a family emergency and is not able to participate today. With that, I would like to introduce Dr. Anita Everett. Anita, do you want to go ahead?
There we go. Sorry. Yes, I'm in transit right now, so a little also because of a family situation. So I'm doing the best I can to join you today, and I appreciate your patience with me as I try to sort of juggle a lot of different things. But we've all become familiar with that, as both Brian and Vijay suggested, the being able, adapting to unexpected events is sort of is one of our characteristics of our time. I do want to thank the National Dialogues for inviting me to participate. I'm a little bit embarrassed to say this is the first time that I've participated in this. It certainly will not be my last. I've heard about this conference for many years from many of my friends and colleagues, and again, I'm very proud to be here. I also want to thank, the National Association of Mental Health Program Directors, which Brian, represents. It's an honor for me to be here among several peers and colleagues that I've worked with on many different projects across the years, and I'm hopeful that we will help to sort of kick off a series of discussions that will help to be thought-provoking for many of us. Okay, so with that, let me go on to my slides. This is my introductory slide. It influences and major trends in behavioral health services, building back better together. And that is certainly something that's associated with this administration, this presidential administration. As a federal employee, a civil servant, I am, it's part of my job to promote activities of this administration. And the notion of building back better, I think, is really important and relevant to the topic of this conference, and something that we are actively working on a daily basis within SAMHSA. This notion of building back better, as I know is the case with many services across our nation. Next slide, please. Yeah, thank you. This is just a little bit of a reference. I know that Dr. Fisher is going to be talking a lot more, I'm predicting, about recovery, but just to have us think just a little bit about the what's going on with recovery and consumers and individuals, all of us actually that are in the world that we're in. Wanted to sort of orient a bit toward the 4 sort of cornerstones that SAMHSA has outlined many years ago to recovery, to successful recovery, and I would submit to you to successful life for all of us. The need for notion of a need for good health, a home to stay, a sense of purpose and community. And I brought that up because, for each of us, or for particularly for individuals with serious mental illness or families that are affected by that, and or serious emotional disturbance in kids, each of those have been threatened in one way or another by the condition of the pandemic, which we're focused on today. So our health has certainly been threatened. We know that around us are reminders of the impact of the virus itself and its impact on everybody. We also know there's been a disproportionate impact on individuals with mental illnesses. The morbidity and mortality is greater in those that receive, that acquire COVID. The recovery is less likely to be as good. It certainly doesn't mean individuals don't recover, but it's a threat. Homes have been, there's been a slight suspension in people who otherwise would have had financial difficulty with rent payment and things like that, but that's we're to the end of that, or different states are interpreting that differently. But the notion of homelessness and the notion of who's at risk to become homeless has certainly been challenged by the condition of coronavirus. The purpose is commonly associated with roles in families and also with employment, and we know that employment stability has been threatened. This does strike me as one possible opportunity for some individuals who've been seeking employment and unable to obtain it, that there may be, since the need for employees has gone up, if anything, that there may be some opportunities there. And then community, our sense of community has certainly been disrupted by the pandemic itself. Our sense of how we're together with other human beings, which we know, particularly in the mental health field, we know is a really important part of a sense of well-being. Next slide. This is an orientation to SAMHSA itself. I won't talk long about it, but just to let you know, CMHS, the center that I direct, is one of 4 main centers within SAMHSA. The other center being substance abuse treatment, substance abuse prevention, and the Center for Statistics, Behavioral Health Statistics and Quality, our statistical unit. We've been very busy, and as a result of COVID, we've actually gotten increased funding through a number of different mechanisms and budgets, and our base budget has gone up by almost 1/3 over the last year to 2 years. Next slide. We've been busy, in other words. This is some of the things that we're looking at internally, building back better, as it were. We've all been very busy. That's a scheduled there from a Teams screenshot. We've been working on our internal staffing, which is important to us in particular, and I would submit also to the nation. It's no secret that SAMHSA has had longstanding employee satisfaction difficulties, and we are actively working on that. This panda there represents a structure that we've created to look at positive work environment affiliations that you would have in work environments, building a sense of community within work, and also opportunities for professional advancement in the work setting. We've restructured some of our branches so that they're more aligned, and we now have a division which works more directly on most of the services or most of the grant programs that look at children's services. So we've grouped them together so we can hopefully be more effective and more influential with our children's services. And then we have our longstanding adult community mental health services branch, and we've coupled that with the suicide prevention branch, which is where a lot of the 988 related activity lives. And then our formula grant branch, which has been the recipient of tremendous new funds related to COVID. I now have that little poem there. It's the piece of the poem from Amanda Gorman that she so eloquently delivered at the inauguration to remind us of the hopeful message that she submitted and transmitted nationally during the inauguration. So we think about that, or try to think about that, in that spoken word poetry style that she emulated so well. Next slide, please. So now I have a couple of slides, a series of slides that are intended to sort of focus on or transmit what it is that we're working on at SAMHSA right now, some of our high priorities. No surprise to this group will be the notion that crisis services are very important to us right now, a high priority. We're working first and foremost, or much of our work recently has gone toward the successful launch of 988. 988 will come from the existing National Suicide Prevention Lifeline. What is depicted here on this slide with the bottom diagram is something that's very important for us at SAMHSA, and that is to keep in mind that the way we conceptualize crisis services, it's not just the phone itself, and we do know that the phone itself can be successful as an intervention, but we also know that more full crisis services involve someone to talk to, someone to respond, and a place to go. And we're suggesting that in doing whatever we can to stimulate the development of all 3 of those lines of services throughout. Of course, on either side of that are aftercare. After there's been an acute intervention, or sort of an intervention that's designed around stabilizing someone, we know that the follow-up is important. And also that we know that services in advance of someone needing crisis services can be very helpful. And we haven't lost sight of that. We're just hoping that these 3 elements of crisis services will increasingly become known as an element of a successful crisis continuum, so that we can more ably serve individuals at crisis. So anyway, that's sort of where we are with that. I see the crisis services myself as an important front door to the entire public mental health system, which has so long had front door problems, access problems. Let's go on to the next slide, please. Another priority for us right now at SAMHSA is the CCBHC model. That's the Certified Community Behavioral Health model. CCBHCs were born by an act of Congress as long ago as 2014. CCBHCs have required clinical elements that are to be provided, and peer services are one of those, which I think is relevant to some of the interests of this audience or this group. The CCBHCs during the last 2 years have received tremendous augmented funding from Congress, And now over the last 2 years, we've had over $1 billion of investment in the CCBHC program, just the component of the CCBHCs that SAMHSA administers. Next slide. There are current CCBHCs are not equally distributed, and this map just gives a flavor of that. We see certain states have picked up the CCBHC model much more prominently than others. And I've also replicated here on the right, those dots give a flavor of what the 9 required services are. You don't have to be a CCBHC to provide those services. And we do the very best we can to assure that all CCBHCs do require all those services, but we know that it's harder to meet some of those services than others. For instance, the crisis center, if a community mental health center has not had a crisis center before, that is a particularly challenging one to develop as a condition of becoming a CCBHC. Let's go on to the next slide. This just gives an idea of the growth of the CCBHCs over the last several years. You see, if you pay attention in particular to the funding line there, or funding column there, you see that the program has increased dramatically. And we also see in the 2022 proposed president's budget, which is under debate as we speak, the president has included $375 million to support CCBHCs. House of Representatives and the Senate, if anything, are predicted to augment that or increase that. Let's go on to the next slide, please. And this is a little bit of a flavor of some of the outcomes that we get with CCBHCs. The number of the diagram to the left there demonstrates the number of individuals served by CCBHCs that would not have otherwise been served had the grantee not developed a CCBHC. So it's a little bit of a hard number. It's not the full number of people that are served, but it's the full number of people who are served only associated with the CCBHC expansion. And we see improvements in housing. We see improvements in illegal drug abstinence. We see improvement in everyday functioning and improvement in criminal justice involvement, so lesser of those. CCBHCs, in short, one of the ways I think about CCBHCs they are the set of services that you would want an individual to have, that you cared about. Could be our patients, could be a family member, could be a peer, could be anybody. They're the set of services that you'd want an individual to have access to everywhere across the United States. Let's go on to the next slide, please. We also, the third program that I brought just to highlight, to give us an idea about what we're building on at SAMHSA, has to do with our school-based mental health service program. This is another service that's been of interest to Congress recently. We're particularly attuned to that right now as children, as we're turning our thoughts to school and returning to school, how kids are doing in school. What we like about this AWARE program, which stands for Advancing Wellness and Resiliency in Education, is that it's typically a three-tiered program. So it has an element of universal intervention. It has an element of looking at the climate of the school and actively addressing ways to build in positive behavioral supports, restorative justice, elements like that apply to all the students and teachers in a school. It has a second tier, which includes identification of kids and families who otherwise might be at some risk. And then the top tier, it would be kids who actually have crossed the threshold into a diagnosis and need treatment. The minority, what I like about this triangle diagram that depicts that there, it's actually the minority, of course, numerically of the number of kids, but there are certain kids, and the AWARE program supports increased access to actual treatment for kids who need treatment. By now, 46 states have been AWARE grantees. That doesn't mean that most school systems, however, have been exposed. When a state is a grantee, they typically pick one or two local education entities. And so given that a state will have multiple hundreds of local entities, we've got a long way to go before we can say that AWARE itself has touched most of the school systems. But it's a very important program that's been very successful. Let's go on to the next slide, please. So this is my final slide. Has to do with looking to the future, and as Vijay sort of referenced at the beginning, we all started out the way we were, however we were, now almost 2 years ago, and then along comes a pandemic, and it kind of derailed some of the plans that we had. Some individuals have actually done better as a result of the pandemic. Most, however, have had a threat to some of the conditions and the circumstances of their lives in association with the pandemic. Some of the ideas that may be changed by the pandemic that may stick with us longer term, in my opinion, at this point in time, involve teleservices. I think, many states as well as the federal government are looking at ways to support on the ongoing use of telemedicine and mental health services. Our style of services in particular are often able to be delivered, if not full-time, delivered at least intermittently by teleservices. And for some individuals for whom transportation is a particular problem, or for whom being out in the public is an anxiety-provoking kind of thing, a kind of an issue, teleservices actually can be more effective than in-person services. We know that equity inclusion, and I'm very hopeful that that will make enduring changes, the work that we're doing now on assuring that we pay attention to what's going on with historic inequity and exclusion in our systems, that we will be able to build in much more attention to and mediations of our services, so that individuals of all sorts have good access to wellness and good access to and full participation in our society, as well as access to treatment where needed. We're particularly attending to this with any kind of attention on 988, so that we assure those services are developed well. CCBHCs, I believe, and I'm hoping, are here to stay. Even places that don't have the CCBHC money, the grant money from SAMHSA and or the demonstration status from Center for Medicare and Medicaid Services, the model is being picked up because it does represent a fairly full spectrum of services that we believe, by and large, individuals with serious mental illness need. It is a treatment-oriented set of services. It's a clinic-based set of services that does have outreach as a component of it. So it's not entirely clinic-based, but I'm very hopeful that more services that have not been able to offer that full set of services will look to the CCBHC model as a model. 988 and crisis services, I've talked about that, but we really are hoping that over time, 988 will become as grounded and as essential to mental health care, behavioral health care, as 911 is now to healthcare. It's taken 911 by parallel about 60 years to become what it is now. It's almost unimaginable at this point in time to think about what it would be like to have an accident on the highway and not be able to quickly dial help, dial 911. We know somebody's going to respond within a number of minutes. And we know we're going to be taken to a place, an emergency room that has doors that are open and is equipped to serve us. We're hoping in a very similar way that behavioral health crises, including substance use related crises, will be able to be addressed fully and in more communities over time when this system is developed and brought to its full fruition. And then also school-based services. I do think that's a wave of the future. We know that we know where our AWARE grants are and where our AWARE grants have been. We also know that our partners in the federal government at HRSA operate a number of school-based health clinics. Often they're based out of federally qualified community health centers. And often those school-based clinics have mental health services as a component of them. So the notion of being able to get attention to children where they are and where they are on a daily basis, I think is a really important trend in our future. Let's see, I believe my next slide is just the closing slide with some contact information. Again, I want to close by thanking Dr. Hepburn and Dr. Ganju for inviting me to participate. I am going to do the very best I can to listen and be to the ongoing dialogue to my co-presenters and join back at the end of the discussion. With that, I'll turn back over to you, Brian, and say thank you very much.
Yeah, and Dr. Everett, do you have time for one question?
Sure.
So you were talking about federal partners, and would you say something about the efforts of SAMHSA to work with CMS in terms of the crisis services, looking at specifically the funding that has come out from the block grant, and how some of the states have been concerned because it's one-time only money, and they look at CMS as being the answer for sustainability. But there has been a long time concern about the federal partnership between SAMHSA and CMS.
Yeah, so part of our building back better sort of notion is reinvigorating many important partnerships across the federal government. And so CMS, of course, is a really important, a very important partner for us. And we are working on many different projects that relate to building connections to CMS. We do recognize that to fund crisis, our money often is used as startup money to initiate services, and partnering that with some of the opportunities that CMS has created for funding crisis services is really important. There have been several recent documents put out. Kirsten would know more directly how to access them, but that have been put out that define very specifically the multiple different routes through which CMS, Medicaid in particular, can be used to access and submit bills and or funding for various of those elements of crisis services. And so, yes, that's a really important partnership for us.
Okay. Dr. Fisher, you had a question? I think you're on mute.
Yeah. Anita, thank you very much. It was a very, very good summary. I had a question. I didn't hear your discussion really of support by CMHS of peer development of peer services, especially state network, consumer-run state network services. And, we run a national technical assistance center that's consumer-run. There's been question whether or not there was a way to expand that even a bit, because I hope and expect that the development of peers will be an important part of the increase in the workforce development.
Yes, we do see that as very important. That has been, we haven't done as much as we might over the last several years, but it is an important part as we look forward to how to sort of develop that out. We were very, very interested in that. So I do want to thank you for that, and also ask you to hold us to that. So it's very important, and we see that as I'm particularly reminded of the attention that we've given to peers in the crisis space, and we have some things coming up that will look at that in particular. But peers are helpful in multiple different sites in settings, as you know. So stay tuned. Let me just say.
Okay.
Thank you.
We'll help you with that.
Thank you, Anita. And our thoughts are with you as you're spending time with your family and dealing with the loss of a loved one. So thank you very much.
Thank you.
Thank you. Let me bring in Kirsten Beronio to give us the answers regarding finance.
Thanks, Brian, and thanks to you all for tuning in and joining the conversation today. I'm going to share some of my thoughts that I actually put together in working with Brian and NASHBID to think about primarily crisis stabilization services, but I think the issues and the suggestions really could be thought about in terms of other issues involving behavioral health care delivery. So can you all share my slides? I think Jessica, yeah, there we go. So we can go to the next slide. And this is just an overview of some of the topics I'm going to cover. I think it's really important to be cognizant of what Anita just touched on, which is a tremendous increase very recently in block grant funding, as well as some really important new opportunities in Medicaid to support behavioral health services, some of which are focused on crisis stabilization. I have tend to think about these funding stream issues on three different levels. One is like the system level, what can, how can we support broader, things like statewide crisis stabilization systems, and what funding is available for that. how can we support programs and things like CCBHCs or other kinds of multi-component, multi-dimensional programs, and then how can we support the providers of the actual services. And so I'm going to talk about the block grant funding with that regard, and then some of those recent some of the challenges around provider implementation costs, some of the recent Medicaid developments, as well as some existing opportunities, that predate some of the recent changes that in ways that Medicaid can support behavioral health care delivery, including, the crisis stabilization focused services. And of course, the new opportunities focused on mobile crisis and home and community-based services, as well as telehealth, very important, I think, for behavioral health delivery going forward. Some critical financing issues there, a key component of crisis stabilization. So next slide, please. Next, there we go. So this slide was intended just to really, highlight the recent increases. So you can see in the first or second column, first labeled column, the 2019 FY 2020 funding levels for the block grants, and then just wanted to highlight that at the end of 2020. There was a continuing sort of the ongoing appropriation and then a supplemental appropriation combined in what was called the Consolidated Appropriations Act. And so in addition to maintaining existing funding and really increasing it a little bit with a set aside for crisis services and, specifically around helping states and localities prepare for implementation of 988, there was an additional $825 million provided for the block grant, and then 1.65 for the mental health block grant, and then 1.65 for the substance abuse block grant, in recognition of the tremendous impact COVID-19 has been having on behavioral health. And then a few months later, another $3 billion total, 1.5 for each block grant, enacted as part of the American Rescue Plan Act. So really, like, a lot of funding coming very quickly at state behavioral health leaders. And so, and then as Anita alluded to as well, we're in, the next funding cycle. The House has passed an appropriation bill earlier this summer that would have continued this higher level of funding for the block grants with a 10% set aside for crisis stabilization. We are currently in a rapidly approaching deadline for a continuing resolution that needs to be passed by the end of today to keep the government open. And there, so that's sort of the focus right now. There was at one point an increase in the funding for the 988 implementation in that continuing resolution, even above what was the funding level for last year. But we'll see how that plays out. But ongoing support, I would say, within high levels of the Biden administration, and then also in Congress, recognizing the need to provide more funding to prepare for implementation of this new national toll-free hotline 988 that I agree with Anita will be a really critically important way to improve access to care. And so that's the way I've been thinking about it. Next slide, please. This slide, I highlight some of the ways that I think the block grant could help, this increased block grant funding could help with building out more services, more systems. This focuses on more of the system kind of infrastructure kind of activities that I think the block grants are really critical for. Medicaid is always pointed to and thought of as the leading payer, the single largest payer, and does have a really important role here. But I think the block grant too really represents a key way that the federal government and state governments partner and does have more flexibility in a lot of ways in what it can cover. You know, and as 988 has highlighted, really just this need for better collaboration and investment at the state level. You know, I think the increase in block grant funds is really coming in at a key time to help with, you know, some of that collaboration. There's a lot of different stakeholders that are need to be involved in a successful rollout of 988. There are some key activities I highlighted here, and in the interest of time, won't go through them in detail, but just to touch on some of the ways I was thinking the block grant could be helpful would just you know, be with supporting some state level efforts to assess the availability of crisis lines and call centers and mobile crisis. What's the capacity that exists now? How are 988 and 911 and any other hotlines and warm lines going to interact and support each other? Thinking about how these systems are going to really respond to the needs of disadvantaged communities, and needs to be very mindful of that issue, and how that has not always been the case with 911 and historically. And thinking about how to, you know, how can electronic systems be funded both at the state agency level and then at the provider level to help track availability of services. If someone is in crisis, how can you get them into care as quickly as possible? Remedying any existing state laws that block the ability of providers to provide care. For example, any laws that block the ability to treat in the field or require transport to a hospital ER as opposed to any kind of crisis stabilization setting. You know, thinking about reimbursement rates, what is currently available in terms of Medicaid reimbursement, you know, supporting providers to be able to bill Medicare and private insurance, expanding the use of peers, thinking through how peers can help with this whole effort that's underway to think through improving crisis stabilization. They play a key role there. And then thinking about data. What's the data infrastructure? You know, how can you know, states and localities assess the impact of the use of the funds and ensure quality of care? So those are just some thoughts. I should have mentioned that there's this presentation is really trying to summarize a paper that I wrote for NASHBID that is available on the NASHBID website. And I have a link to that paper at the end of the slide deck. So hopefully you'll be able to go to that for more details. Next slide, please. I mentioned that some of the issues around you know, improving access to care, responding to the, hopefully we hope, you know, outreach and need to respond to people seeking care and in crisis is really helping the providers to improve their capacity. Right now, we're, you know, the association I work for represents large behavioral health care provider systems, and I hear all the time about shortages, workforce shortages. That is certainly a big issue. So help with thinking through how do they fill staffing gaps, hiring staff, better utilizing the staff they have. Implementing telehealth is a key piece there, and trying to leverage that and the improved coverage of telehealth that I'll talk about a little bit later. You know, we saw recently some data came out highlighting just the degree to which psychiatric settings anyway are lagging behind in implementation of HIT. This is not a secret, it's not news, but there was some really startling data showing the disparity there, and that's a big gap. And potentially some of these more flexible funds that have been coming out could help with some of those costs. One big barrier is, of course, that the block grant funds anyway traditionally cannot be used for construction costs, even though there is really, I think, a need for more capacity. You know, building out more of these kind of crisis stabilizations settings to help respond to 988 calls, for example, as an alternative to emergency rooms. I was just in an emergency room last night, actually, by the way, and it was packed and just not dealing well with at least one individual who was there with a behavioral health condition. So I've experienced that firsthand very recently. So just need to really help with thinking through how do we build up more of these alternatives, more of the walk-in capacity, more of those kinds of settings, and thinking about special populations and how do we address the needs of children. We've heard data, during this pandemic of just the terrible impact on children's behavioral health and adolescent behavioral health, and the need for to think through how do you best address those needs. Probably not in an emergency room, and probably not in a setting that's really, mostly targeted to adults. I did want to flag there were a couple other, in addition to the block grants, Congress has been busy with providing other funding. I just mention a few here at the bottom of the slide. There was funding coming out through the Treasury Department recently to states and localities, and specifically referenced that funding could be used for behavioral health, including hotlines and warm lines. In the paper that I mentioned, there are links to the websites where you can see where that funding has gone. Don't think there were some of those same kinds of limitations around capacity, capital costs, construction costs. So maybe an opportunity there. Also, the House anyway has reinstituted a practice of providing earmarks and appropriations. And so the labor HHS appropriation that was passed out of the House includes a number of earmarks targeted to behavioral health, and really some of them focusing on this need for building out new kinds of settings. So next slide, please. And now onto Medicaid, and thinking about how Medicaid can help. Medicaid, generally think about it in terms of as a coverage program, that it covers services, but it also can help states with infrastructure and administrative costs. There's an administrative match that's available. There's one resource on this topic I wanted to highlight was this state Medicaid director letter from November of 2018 that focused in on how Medicaid can support innovative delivery systems for individuals with serious mental illness or serious emotional disturbance. The first part of that letter really does talk about existing Medicaid authorities that can help with different evidence-based models of care, and did talk about crisis systems and the need to and the availability of this administrative match for some of those components of crisis systems, including, for example, the Georgia Crisis Access Line, I know does access administrative Medicaid reimbursement for help with running that critically important service. That letter also highlighted a number of, another authority in Medicaid that offers an enhanced federal match for technology-based activities that the state undertakes to improve care for Medicaid beneficiaries, offering a 90% match, and for implementation, 75% for operations. And the letter really flags some ways that you could think about that enhanced match supporting crisis services. And then there is an authority within the CHIP program for health services initiatives. Again, more of like an administrative match within CHIP. And those funds can be used to target funding to services for children and youth. For example, some of the states have used that discretionary type of funding within CHIP to fund behavioral health services and emergency response, more targeted to poisonings so far, but you could see a similar kind of idea for a hotline around behavioral health crisis going forward. Next slide, please. And the same state Medicaid director letter also just describes and highlights, the types of services that can be covered that might be offered in a crisis stabilization situation. So there's a list of those services there that are pulled from that letter. But some of the key components of this type of care that the letter talks about as being more challenging to directly cover are things like outreach and engagement, team coordination and supervision. Those can be, the letter talks about how they can be kind of built into the reimbursement rate for coverable services, but we know that often those reimbursement rates are not adequate as it is. So, it's something that not a full solution. I did want to highlight, in addition to the letter, does talk about a Section 1115 demonstration initiative that allows for coverage of, settings that qualify as institutions for mental diseases, which are traditionally not covered under Medicaid. But in this case can be covered if it's part of a full effort at the state level to really build out a continuum of care, including crisis stabilization services. A number of states have implemented this kind of approach focused on substance use disorder treatment, and that was established in earlier state Medicaid director letter, over 30 states now. And this 2018 letter talked about a similar approach for serious mental illness. 7 states have been approved for that now, with another 6 pending. So that's one approach to one gap in the continuum around more of like the crisis stabilization that needs to last overnight or for a couple days. That can be helpful for that level of care. But I think I wanted to highlight what I think is really critically important within Medicaid is to think about how to pay for these services in more of a team-based approach. That is an approach that several states have gotten approval from CMS to take, and it really kind of bundles the services together. I've been warned against using the term bundle because I think the idea was to be a little broader than just covering all the services that are already directly coverable, but sort of expanding to incorporate some of those other kinds of connector services like the outreach and engagement and coordination pieces as part of that reimbursement rate that is more team-based. So I know some states have been successful in this. Again, point to the paper where I was able to flag some of those examples in more detail. And managed care can also offer some flexibility in that regard, as Arizona, for example, is a great example of. So next slide, please. And then now on to the newer opportunities. As I mentioned, through recent legislation, the American Rescue Plan Act specifically, this is a great new opportunity, encouraging states to implement within their Medicaid programs coverage for mobile crisis by offering this enhanced match for 12 quarters, which is more generous than I think I've seen in recent times. Usually it's an 8-quarter approach. So, and I know a number of states are, for example, Maryland, applied for and got the planning grant, and they had not previously covered mobile crisis in Medicaid. So, maybe Brian has some more comments on that. I think this is a great opportunity to really build out a really important component of crisis stabilization. And just improving access to care in general. There's some of the requirements listed here. It's got to be for services outside of a facility. It's got to be a multidisciplinary 2-person team available 24 hours, 7 days a week, trained in trauma-informed care, including a professional authorized to conduct an assessment, able to provide screening, stabilization, and coordination, has relationships with local medical and behavioral health providers, and that the state is not supplanting something that they're already doing with this funding. So if they already were covering mobile crisis, they've got to be able to demonstrate how this, they would be expanding availability of those services. The American Rescue Plan Act also provided funding for planning grants, as I mentioned, And just CMS did just award those earlier this month on September 20th to 20 states. So I'm hoping that with that planning grant funding, that again is a little more flexible, not covering specific services, but able to, state Medicaid agencies can use to kind of think through and plan and be strategic, that will be a way for the state Medicaid agencies to engage with state mental health and substance abuse agency folks to really think about crisis stabilization, how Medicaid is going to be a component of that broader system, and really think about, kind of how to fund these services, which, are not, as I mentioned, this team-based approach is really intended to more get at the fact that the services have to be available 24/7. You can't just reimburse on a service by service basis. There's built-in additional overhead costs there that need to be taken into account. So next slide, please. And this is the other big opportunity in the American Rescue Plan Act that authorized a 10 percentage point increase in federal match for home and community-based services during this first year from April 2020 to 2021. And that bump in federal Medicaid funding can be used for either or improvements to home and community-based services or expansions during a 3-year period. In terms of the expansions, the extra federal funding actually can be used to cover the state share of that expansion during that first year. So kind of a very rare opportunity there. And that coverage can only happen during that first year and only be matched at the higher rate for one time, but a really kind of key opportunity there to really leverage some additional federal Medicaid funding. The requirement, there's requirements, of course, around maintaining coverage and maintenance of effort requirements, basically. And then, but it was also interesting to see that among the home and community-based services that are eligible for this higher match or for this reinvestment opportunity for broader expansion, the Medicaid rehabilitative services option was flagged, and that's a really key Medicaid authority that most states use to cover home and community-based services for people with behavioral health conditions. There were a number of other authorities like 1915I and Section 1115 demonstrations that were also eligible for this enhanced match and reinvestment opportunity. So hopefully that can be leveraged as part of the effort to think about Medicaid support for expanding crisis stabilization services, as well as other behavioral health services. And then in addition, or instead of the expansion, there was a state Medicaid director letter that was issued in May of this year that highlighted a number of activities, again, more of these like infrastructure building kind of activities that the additional federal funding could be used for. And those were laid out in some appendices to that letter, long list. Most of them rather, behavioral health was there. Most of the kinds of costs were kind of more oriented towards people with physical disabilities and helping with those kinds of services, but easily translatable to thinking through, use for helping providers with telehealth technology implementation, helping mobile crisis teams with iPad, having iPads so that they can communicate back with folks in a clinic setting or a crisis stabilization setting to help with care, language assistance, marketing of 988, for example, to help spread the word. Those kinds of costs, I think, are all could well fit within the bucket for this additional federal funding. And although states were required to submit plans back in the spring, I think they were fairly general. So there's still opportunities, I would say, to work together with Medicaid agencies on rolling out that funding and really helping to ensure that it goes to helping with behavioral health. So next slide, please. And this is my last slide, just again on telehealth, such a key component of crisis stabilization and such a critical tool during this pandemic. I know for the members of NABH, it's been really life-saving. And even as other kinds of services, we've seen declines in utilization of telehealth. The use for behavioral health has really continued to be maintained at a much higher level than before. It's critically important for folks living in rural areas and underserved areas, populations, even within urban areas. And there have been some recent really important Medicare improvements that I wanted to highlight. Medicare does often influence other kinds of coverage, so in commercial insurance and Medicaid certainly. So I'm hoping that with these improvements that Congress and CMS has put in place, that can have a broader impact, so that even after the pandemic, mental health and substance use disorder treatment can be covered via telehealth in an individual's home or community, regardless of geographic location. Those are some key limitations that exist more, exist more broadly for other kinds of services, and were changed to allow for telehealth for mental health and substance use disorder treatment specifically going forward after the pandemic. This change also actually includes the way it was done. It actually will result in reimbursement rates being the same as in person. However, unlike during the pandemic and emergency authorities where we did, CMS has been providing facility fees, there's challenges there with going forward with those kinds of costs being covered for telehealth. CMS has proposed to continue audio-only telehealth for mental health and for opioid treatment programs, not for substance use disorder treatment more broadly. So, kind of a limitation there that we're hoping to improve upon. And there is also a requirement in statute that someone for mental health telehealth has to have been seen in person within the prior 6 months, which is a significant limitation that we're hoping to improve upon. So with that, I think I'll stop, and we can go to the next slide, which should show the link to the paper on the NASHBID website that includes all of this information and more. So happy to take any questions.
So Kirsten, that was really good. So thank you for that overview. One of the things that I think many of us emphasize is what Anita said, and that is that crisis services are now being seen as often the entryway into the system, in many ways the way the emergency room previously was. And now with that, you end up having the problem of, well, how do we keep people out of crisis, or how do we help people recover from crisis? So the emphasis on prevention, early intervention, so that people don't go into crisis. And then the recovery type services, housing, employment, that may help to decrease that cycle of going in and out of crisis. Do you have any thoughts on that?
You want me to solve all the problems?
Yeah.
I think that some of those other issues are really critical. I think crisis stabilization only goes so far. It is a key way to, I think it's captured a lot of people's attention and excitement because of 988 being this really important new tool that we see so much potential for, but that's not obviously going to solve all of the issues. And I personally think, with prevention and early intervention, integration is really key. School-based behavioral health services are really critical. Some of those kinds of, those raise a whole other set of funding issues and policy issues going forward. But I do think as part of crisis stabilization, sometimes that's when people do access care for the first time, and making sure that they are getting connected with care if they, choose to pursue that and, need it. it should be a critical part of these programs. So having some sort of follow-up, outreach to people, just as we've encouraged in inpatient settings as part of these crisis stabilization centers, I think will really be important for just, other outside of a crisis situation, really helping people get access to the type of care and level of care that they may need.
Well, thank you. One of the things that I think is really exciting, as you addressed, is home and community-based services. For so long, we looked at home and community-based services as really not being helpful for behavioral health. It was often used for the IDD population, and they took advantage of those services and that funding much more than behavioral health did. I think what you've pointed out is that the new interpretation, the new guidance really allows home and community-based services to be used in a way that we have not used it before in behavioral health. If it's being used to keep people out of institutions, you can use home and community-based services. Could you say a little bit more about how you might be able to use home and community-based services for example, supported employment?
Yeah, supported employment. I think there are a number of states that do use some of those authorities, the rehab option, for example, to cover supported employment. 1915I, certainly. I think with some of the authorities, there's certain technical challenges around some of the components of supported employment. But I think as we've seen consistently in research and just anecdotally, the importance of helping people get back to work or get back to school as a component of their recovery is just a really critical piece. I am hopeful that that CMS could do some more guidance in this area. I think there were efforts historically to try to highlight this that got kind of caught up in work requirements and other things that were going on at CMS that were more problematic. But with this new administration, I hope that they do revisit that, because I think it is so important, and Medicaid can really, there are authorities there that can be used to help people get access to those services.
Okay. Thank you. So with that, let me introduce Dr. Daniel Fisher. And Dan, you want to go ahead?
Thank you, Brian, and thank you, Vijay and Kirsten. I'm going to take a slightly different approach. This is we've been sort of at 40,000 feet, which I think is important to look at. I'm going to enter this conversation from the place of people recovering, and really in the relationships that can be formed. I haven't heard a lot of discussion about recovery and the principles of recovery. This was a big emphasis at SAMHSA prior to the previous administration. There seems to be now, once again, interest in supporting recovery, and both from mental health issues and from substance abuse side. Also, the role of peers. We really need to highlight that this was a big development for about 20 years. I was a member of the White House Commission on Mental Health, and one of the cornerstones of that was that people lived experience would play a central role in not only the delivery of services, peer delivered services, but also in the formation of policy. And this has also been sorely missing for the last 4 or 5 years at a federal level. We had, prior to that, played quite an active role in the creation of new programs, programs that really help with crisis, such as peer-run respites and recovering learning communities, and training peers by peers, and getting reimbursement for peers working in a variety of settings. Prior to this, the formal part of this program starting, I just sort of made an aside remark that many times the solution seems to be there are not enough workers out there, not enough mental health workers to meet the needs. We have increased needs. We have decreased availability sometimes of mental health professionals. And sometimes the idea is just hire a peer. And that falls far short of what really is needed. And one of the reasons is that many peers don't really want to work in an untransformed system. We used to talk about transformation of the mental health system, but I haven't heard a lot of discussion of that over the last 3 or 4 years. Hopefully that will be brought back also in this Building Better Tomorrow. In order to work in an outpatient, inpatient, crisis team, any one of the clinical areas, people lived experience want to experience those settings as being less stigmatizing and more recognizing of the value that peers can offer in those settings, not just as providing support, but really at every level of a clinical center or a clinical service. I myself, I just say a bit about, people don't know what I've been doing over the last 30 years. I was hospitalized in my 20s, was diagnosed with schizophrenia, and decided that I was so dissatisfied with the treatment that I received that I decided to become a psychiatrist to try to change the system. And one of the, and some people might say I probably remain mentally ill if I thought I could, as a psychiatrist, change the system. What I did learn was I could make small changes. I worked as a medical director of a community mental health center for about 25 years. But I also found that the larger changes require a lot of advocacy, advocacy from people who lived experience, advocacy from family members, advocacy from online workers, advocacy from administrators, and the general public. And the increase in crisis services and the 988, I think, is a step in a positive direction, because it does make more services accessible earlier. But I worry that there's a cliff that follows this increased access. If you have increased access, but you don't have any increase in capacity, you're really going to set up people for failure and really for frustration. Stabilization is really just a small beginning. Usually the difficulties that lead to severe psychiatric problems have many preceding problems. And as Brian was saying, they require an ongoing recovery experience. And the recovery can be quite lengthy. I'd say for myself, it was probably about 5 or 6 years before I was able not just to recover, but to actually transform my life. And it is an opportunity to grow often. These problems, though they're viewed as illnesses, they're usually telling us a great deal about ourselves. I'm going to be specific about what over the last 12 years I and our national center have really worked on. I run a center called the National Empowerment Center. We've been around for 30 years. Our major focus has been to bring just one very significant change in the mental health system, and that is that people can and do recover from even the most severe psychiatric problems. And this would seem like a small step, and yet without that step being established, all services end up being stabilization. Even the word crisis stabilization, I keep hearing stabilization, stabilization. People want to grow. People want to have a fuller life. People want to recognize that being labeled with a psychiatric problem is not a death sentence, but is actually can be the beginning of a change in people's lives. If the proper supports are there, if the proper hope is given, if people are able to gain control of their lives, if self-determination is part of it. So we've interviewed many times people who have succeeded, like myself, in going from a severe psychiatric condition to leading a fuller life. And we asked them, what are the most important components in that experience? And repeatedly, those components, and SAMHSA has played a very important role in establishing the components of recovery. And repeatedly, they involve relationships. They involve how people can establish the types of relationships that enable them to have the social supports that they need to not just stabilize, but actually to have meaning and purpose in their lives. I was interested in Anita's description of the different areas, the different realms of recovery. And one of the most important and neglected is community, and that is belonging to a community, having a sense of community. And we can find a home. Housing First is certainly a good example of that. And yet, if people have no community, they'd sometimes rather be back in the hospital. People actually feel sometimes a sense of community more in the hospital than they feel in a single occupancy home. Hospitals, I don't feel, are a good place to live a lengthy life. That leads to institutionalization and passivity, dependency. But why do people end up in a revolving door? It's often, I remember myself, I was hospitalized 2 times. I was trying to go back to work as a scientist at the National Institute of Mental Health, measuring chemicals and neurotransmitters, and ironically. And I remember going by a hospital and thinking, gosh, I got my meals provided there. There were people around. I wasn't alone. There was a roof over my head. I had a sense of security. And sure enough, within about 6 months, I was back in my 3rd hospitalization. I had not addressed, though, one of the most essential points, and that is overcoming isolation and loneliness. And we seem to have done a reasonable job in providing case managers, in having maybe a clinician or group therapy, or sometimes clubhouses can even be helpful. I think clubhouses and the Fountain House model have some merit. But each one of these is a service. Each one of these is, how can we serve you? How can we provide a service? I mean, even that language, so that you have a consumer. We hate the word consumer, by the way. We use the term people lived experience because we are people first, just like people with other disabilities are people first. Well, I'm going to talk about a program that we've developed as a way to possibly solve this problem of social isolation, which, by the way, under COVID has only been intensified, both by the virus itself and by the steps that are necessary in many ways to take in social distancing, and even wearing masks have intensified this isolation. So I'm going to see if I can share a few slides with you. And these will describe to you the program that we've developed. We call it emotional CPR. And this is using the analogy to CPR, which is where people physically, their heart stops, and physically a lay person can restart their heart. This is emotional CPR for people whose emotional heart has stopped. And it can be applied really by your being with another person in such a way that their emotions are restored. And this can occur either with lay people or with professionals. It was been developed over the last 12 years by people who lived experience, because we felt that it was important to fulfill these principles of recovery. These are nice principles, self-direction, it's a very important component, but you get that from supports. You can't be self-directing if you don't have supports from other people. Empowerment, always mention, people want to gain control of their life. They want to have a voice in their life. Again, it exists in groups. You don't have a voice in isolation. You gain a voice by being with people who help restore your voice, and mutual support. We need to move away from it's always someone helping, always someone helping. how do we help each other is very, very fundamental. And this is something that Brian was talking about. How is this going to help people recover in the community? It'll help them overcome the sense of isolation and the sense of powerlessness. And this is made even worse by the disaster of these emotional pandemic that we're facing and will face even more seriously as a result of COVID. We found from Katrina, we found after 9/11, that people don't need to have increased labeling and increased services for individuals. They need something much more group-oriented, much more community-based. And community counseling actually emphasizes how can people actually help each other? How can people provide peer support and self-help, not just in a clinical setting, but in a more autonomous setting? And respect for differences as well is very important and can be established through peers. So we learned through teaching emotional CPR during the COVID crisis that we could actually switch to online. I never thought that we'd be able to. When we teach emotional CPR, there's like 12 to 14 people, and it's a 2-day program. We always had done it in person, but within a month of COVID crisis beginning, we started teaching it online. And we've now had probably 150 of these classes worldwide. And it goes across cultures very readily because we really emphasize what does it mean to be human? What does it mean to connect with another person? What does it mean to really support them at an emotional level and really understand yourself and understand other people at an emotional level? These problems are primarily emotional, and yet we hardly hear any discussion about how people can develop their emotional life and develop their emotional connections. So we teach it online. We've also learned that it's trauma informed. We really, as a result of trauma, have found that many of the conditions of mental health are trauma induced, and so the system wants to be trauma informed, but doesn't know how to implement that. Well, the 3 primary ways that we address trauma is we address the alienation and isolation of trauma by connecting people, especially at an emotional level. We address the powerlessness that people experience as a result of power by helping them have a voice. And we address the emotional numbness that people have as a result of trauma by helping restore their ability to feel feelings and to express feelings. We've learned that not only is emotional CPR helpful in healing the trauma that leads to mental health conditions, but it helps heal the community trauma such as caused by the pandemic. And it's interesting, in these 2 talks so far, I haven't heard very much discussion about the impact of this pandemic on people's mental health. We can't just focus on specific individuals. We have to see that this pandemic is affecting everybody's mental health. Everyone is feeling isolated. Everyone is feeling kind of helpless. So we need to bring everyone together in some way. What we then have learned is that we can provide emotional CPR in a community fashion and in a group fashion. And we call this application of emotional CPR community CPR. And the goal of community CPR is to spread the lessons that we've learned in emotional CPR to the broader community. And this is what we've learned in disasters, as I mentioned earlier. And it is a community CPR is an application of public health principles of disaster relief to the emotional impact of the pandemic. So I'll give you just a little description here of the levels and the historical development of what we've been doing. We started one-on-one. How can one person help another person through a crisis? And by the way, all the discussion of crisis services, I think, is terrific. What are we going to do to train all the people that are providing these services? I was trained as a psychiatrist. I didn't feel like I had adequate training on how to help somebody who's in an emotional crisis. We've gotten so used to refer. Well, who are we going to refer to? We need to have in this stabilization units and peer-run respites and mobile crisis teams and first responders with police where we can't find other crisis teams. these people all need a different kind of training on how to be with somebody when they're very upset emotionally and not immediately feel like they have to apprehend them. They have to take them to a restricted environment, or they have to medicate them right away. But how can they be with them? So we learned this one-to-one. We call that really a pair emotional CPR. It's right in the center there. And we then started recognizing there is me CPR, how people are able to apply these principles to themselves. We CPR in a small group, and that's when we grew to community CPR. This is just a summary of how emotional CPR addresses the impact of trauma, that it helps with emotional connection, helps with people to feel their power, and helps people feel revitalized. So the C is for connecting, the P is for empower, and the R is for revitalize. 3 simple steps. You can remember: connect, empower, revitalize. Not so hard. What's hard is to learn how to connect on an emotional level. What's hard is how to be with a person in such a way, and I'll just skip to it. This is a drawing that sort of encapsulates what we try to do. And it actually is inspired somewhat by another approach, which I really recommend, and that's open dialogue, which is a very innovative approach to going to people's homes. I haven't heard a lot of discussion of this, but in Finland, they have shown that if they send out a team, not just a crisis team, but actually a therapy team that provides network therapy in people's homes, they can shift them from the figure over on the left, where you have one individual who is experiencing the possibility of going into psychosis or going into schizophrenia. You can address, connect them with their small group that they live with at a heart-to-heart level. They've been able to show about 85% healing from what otherwise would probably become schizophrenia. We use this similar model and recognize that many people in our society get dissociated from trauma and loss. And the figure on the left is the product of that trauma. And we say trapped in monologue, trapped in your head. And their heart and their feelings are separated out. We, through this approach of emotional CPR, help people to connect at a heart-to-heart level so that they're restored as members of the community. This is just a sort of a drawing of what we think occurs on an emotional level in groups of people who are able to connect at a heart-to-heart level. This is, we don't usually at, I don't know, federal meetings or large behavioral health meetings talk about connections at the heart-to-heart level. And yet what we find is this is essential in people's well-being. This is essential to people's sense of meaning and purpose in life, is that they can actually connect at a heart-to-heart level. And it, don't want to go too far. I know we want to leave time for question and answer. I can, people can reach us. There are many more slides here. This is also helpful in suicide prevention. Typically, people don't really want to talk about ending their life if they're confronted with a battery of questions initially. But if people first can learn to connect on an emotional level with someone and really show a sense of compassion and caring and being with them, then people will be able to be more honest about whether they really are thinking of taking their life or not taking their life. And this is crucial in terms of planning. Is this person safe to go home? Do they need maybe some supports at home? Or do they need more intensive settings such as a respite or stabilization or a hospital? So if people want more information, we can be reached through the National Empowerment Center, that's powertoyou.org. We're funded by SAMHSA as well as by our own services. You can also reach emotional CPR, more about that through emotional-cpr.org. And thank you all very much.
Dan, thank you very much. And thank you for your message of hope and growth. I think often we hear the negatives regarding mental illness, substance use disorder, but we don't hear hope along with it. We often hear it's life ending. And what you said is very important, that there is hope and there's an opportunity for growth. I also wanted to take the opportunity to ask you if there's anything else you wanted to add. I know you rushed through the last few slides. We have time though, so if there's if there's a message in there that you wanted to add, please feel free to go ahead and do that.
Well, thank you. Especially since Anita's here, I'd like to add a message for SAMHSA. SAMHSA was a flagship for recovery. So SAMHSA was a leader in peer support. Honestly, during the last 4 years, SAMHSA de-emphasized greatly. I think, you know, some of the things that SAMHSA's emphasized, they certainly are important. And there was a need for some balancing. I will say that too, as a psychiatrist. But I hope and pray that SAMHSA once again will step forward and be a leader in the supports of recovery and engage those of us who want to help in the development of new policies through SAMHSA. And we once had a voice. We once had a consumer advisory group to CMHS. A very concrete step would be to reestablish a consumer advisory group to CMHS, because, and this would go a long ways towards restoring a sense of trust and a sense of hope for people across the country. And this country also, by the way, we developed recovery before most other countries. We developed peer support before most other countries. And a great deal of that we owe not only to SAMHSA, but a predecessor of SAMHSA, the community support programs, so CSP programs, actually as far back as NIMH. So it has quite a terrific history. And that history, I think we can pick up again, and we'd like to see it restored again.
Anita, do you want to respond to that?
No, I mean, I think we're aware of those gaps, and I really can't preempt anything that we've got going on, but I think we're headed in the direction that Dr. Fisher would be pleased with.
Great.
Very glad to hear that. And I have seen signs of it, by the way. Definitely have.
Thank you, Anita. Dan, I wanted to support what you had said about the importance of recovery and in the importance of those things that we sometimes don't think about, and that is the community support, bonding, trying to remove people from isolation, trying to connect. And I want to give an example. I was at a meeting this was at SAMHSA actually a few years ago, and it was on coordinated specialty care. And there was a young woman there who had been involved in a program, a coordinated specialty care program. Some people call them first episode psychosis program in Maryland. And I was talking to her because she had done well in the program. And I asked her what made a difference to her. And of course, I'm also a psychiatrist, and I thought, well, maybe the medication helped. And so when I talked to her, I asked her, what is it that made a difference? And she said, staying up with my peers. She said, when she had a psychotic episode. When I had that episode, I was scared. My family was scared. We didn't know what to do. We got involved in this program. They provided not just family therapy, individual therapy, but they provided support for her education. And she said, getting that support for my education, staying up with my peers, being able to go to college, being able to graduate so that that gave me hope. That gave me faith that I could do it and I could move forward. And I said, well, do you still hear voices? And she said, yes. But she said, I'm able to function beyond it. And I'm able, with the support that I get, I'm able to do my job. And she's a nurse. To this day, she's a nurse. So I just wanted to use that as an example that often, if we have a professional role, we're often impressed by our own role in the recovery of individuals. But I think what you pointed out is the importance of things that we often may take for granted, but just the simple connection is very important. So just wanted to get your thoughts on that.
Well, yeah, I'm glad you bring this up, Brian, and hope as well, to emphasize that. Typically, unfortunately, a lot of times when people are diagnosed with a serious mental illness, they're sometimes absolutely told they won't have a future. And that still goes on today. I have mothers and young people. Typically, a mother with a young son in his early 20s comes to see me, and I say, I'll see the whole family. I'll see you all. At first, they're a little surprised. Why would that occur? And I said, because recovery takes place with the family also. And I don't blame anyone. No one's blame. I don't blame the parents. And that's the thing about open dialogue. That's what I practice. And I don't blame the individual. I say together, we can find a path to recovery together by restoring those relationships one at a time. But the way I picture it is that when you're in severe distress, and I look back at my own and all the thousands of people that I've seen, it's as if a part of you, an internal part of you is missing often. And all you are, that picture that I showed of monologue, is you just have one version and you haven't incorporated in a sense of self that actually enables a second or a third opinion, so that all you can see is your own reaction. And what's desperately needed at times like that is a trusted other person who can act in a way like well, it's a different kind of ECPR, extracorporeal CPR. They're now doing this with heart-lung machines. And it's actually a way that if you bring somebody to the hospital and their heart is stopped, you quickly attach them to a heart-lung machine. Well, when somebody's in psychosis or in a severe emotional distress, they need an emotional heart-lung machine with them. And that can often only be provided by one or several other people. But those people have to be fearless, they have to be hopeful, they have to be interested, motivated, they have to have a passion for what they're doing. And often, not always, but many times, people who've been through our own recovery know how to tune in because we've been there. And so we can just be with the person, sort of like a auxiliary sense of self. And being with them can help them establish what their goals are. You know, if you ask somebody, we want person-centered planning, and that's a good goal. But if you ask most people who are in the midst of a lot of severe distress, what is your plan? They'll say, I don't know, I don't even have a future. I can't even think of the future. But if you have someone with them who they can turn to them and say, well, let's talk about it. Maybe there are things that I enjoy. Maybe the things I used to do. Because having a psychiatric problem is not so much a problem of a loss of dopamine. It's much more a loss of dreams than dopamine.
Thank you. That's very well put. The next question I'd like to open up to all of the panel, Daniel, Kirsten, Anita, and it's partly to cover a little bit of the area that Dr. Morgenstein was going to cover. And that is, he's an expert in disaster preparedness. He was going to talk more about the impact of the disaster. And so maybe you could address the population impact, and Dr. Fisher addressed this a little bit about how we're all in this same situation. We're all impacted by COVID, but if you wouldn't mind addressing that. Also, the impact on kids, the impact on special populations, and the impact on individuals that prior to this had serious mental illness or serious substance use, and what was the impact on them? So Anita, do you want to start?
Yes, thank you. Yeah, I sort of was thinking a little bit about a way to frame that would be to sort of look at those four cornerstones of recovery that SAMHSA has outlined, the notion of health, home, purpose, and community. And Dr. Fisher's really pulled out the sense of community that's so important, but I want to suggest that those other elements, are important too. They're a pretty good foundation, and they've all been disrupted in one way or another by COVID. So the traumatized and at some level disrupted at the very least. And so it is a way to think about the disruptions to home and stability of that, and people at risk for homelessness, the disruption to health that all of us are experiencing. And even, a lot of us are worried about what kind of education we've given to America's children with regards to how they even weigh information on health information, safety, and various things. So there's healthiness, but there's also health literacy, so to speak, where we are with regards to that. And then, the notion of purpose. A lot of our purpose, I think, comes from, work, a sense of community, a sense of sort of what moves us in life. And that's been altered significantly as well as a result of the pandemic. So we've all had to make adaptations. And I still do see individuals in clinic, so to speak, a lot by telephone, people that have worked for a long time. And some of the folks I work with that are, shy, a little socially anxious, are actually kind of relieved to not have to come into clinic. The telephone visit really is a good way to interface for them. Over time, that's probably not going to be the way things settle out entirely, but having some ability to do that is a really good idea. Others really miss even the notion of coming into a setting as a kind of a way to see the same people on Thursday afternoon in the clinic and have a little bit of sense of community. Not that we would want anyone's identity necessarily to be, that you go to a clinic per se, but there's a sense of community that's been disrupted on so many different ways for so many different people. The regular interaction that you have with the grocery store clerk that now is different because you don't go to the same grocery store, or you get home delivery or whatever. All those things have been disrupted.
Kirsten, do you have any thoughts on this?
Yeah, I mean, I think, in a longer version of my slide deck, I actually had a whole slide on the context and just the behavioral health impact on the delivery of services and supports for people, more focused at the higher, 30,000 foot level in terms of the federal national data and what we're seeing there in terms of the overdose. Unbelievable increase in overdoses as a symptom of that impact. Just the data around kids in emergency rooms with suicidal ideation, just a lot of indicators of very significant impact, understandably, of what we've been experiencing. As I mentioned, I think, as Anita also referred to, that the availability of telehealth has been critical, and we are really working hard to continue, to push for continuation of that going forward. I can't imagine, it will be entirely rolled back, but there's serious threats on the horizon once the public health emergency is over. That some of that coverage that is enabling that access will go away. So that's one of our priorities right now is really strengthening and advocating for continuation of some of those services. Even things like group therapy, that has been, something that our members in an ABH have used, have been able to use telehealth because of the coverage being available. But that's, I think CMS is indicating some interest in continuing that in their rulemakings, and we're very supportive of that. But that's sort of my perspective coming at this from financing and funding streams. How do we think about this looming and already continue, greatly heightened need for care, and certainly crisis stabilization doesn't solve all of it at all, but it's an opportunity that has garnered a lot of attention to some of these issues currently at the federal level.
And Kirsten, you said you were in the emergency room last night. So I wanted to ask you this question, and that is, one of the concerns that we have is exhaustion on the part of direct care workers, even if you're doing telework, it's exhausting. There's no relief from it. COVID is always in the background. And also you have the additional pressure of people who are working in behavioral health and in physical health care that we've seen an anti-public health position that we really haven't seen in the past. There may have been antagonists, but we haven't seen it to this level before. Any thoughts? Was there anything you picked up in your experience in the emergency room that made you think that those individuals were really being impacted by COVID?
Yeah, I have to say my experience was really, I was heartening, just the wonderful care that we actually got in my family. I went in there fully expecting, to see that fatigue, because I've heard so much about it. And what I did see firsthand was shortage of staff and the impact of that. But in my personal experience, I was just amazed at, the people and just how kind and wonderful they were. As I said, though, there was someone there that was really seriously having a very serious behavioral health issue, and they were struggling with that individual. I don't know what the situation was, but I think there's it's just I imagine a lack of someone there who with the expertise to really adequately address the situation. And I think it resolved ultimately, and it was I don't know what happened, but there was a lot of commotion and it went on for quite some time. And I just thought, I bet this could be dealt with in a better way with someone who had some expertise here. That being said, we do hear all the time, and my association from our members, about the fatigue and the shortages, and it's just unprecedented is what I hear from people who have worked in the field for a long time and have settings in multiple states. That the degree to which there is just and I hear about this in other fields, but I think it's particularly alarming as we know there's just going to be such an increased need for care. There's just a need to really think about, as someone put it recently, really creatively, because we're not going to grow new staff overnight necessarily. We need to think about peers, but peers can, they have a role, but we can't put too much in that bucket. How do we, really think about some of the limitations that have been put in place that in laws and regulations that maybe need to be re-examined, just really think better, harder about how to use the resources we have while we're building up more resources.
Yeah, Daniel, you don't want to go ahead?
Yeah,
I want to bring up sort of something about our paradigms too. We've been very focused on a very individualized way of seeing these people's problems. So individuals are diagnosed, individuals are treated. And I think that's why much of the reimbursement system is around individuals. It's very hard to reimburse for a family or for a group. So they're hard services to grow. It's hard to get reimbursement to go to somebody's home outside of a facility. But more deeply than that, what peers really yearn for, and when they say, we all say we want a recovery-based system, not just add peers to the existing system, is we want a change in the paradigm. We want a way of thinking, a way of approaching each person, where we look at their whole context, we look at their social and their environmental and their family life, and we understand that the problems that each person brings are part of a context, and we can't solve the housing crisis through mental health, but we can be aware of it and we can advocate for it. In Massachusetts, 2/3 of our mental health budget goes to housing, actually, because that's such a need. The other thing is, if we have a more group model, a more interpersonal model, then peer support is not just a support for people who are mentally ill while they, reduce their symptoms, but is actually part of their healing and part of their integration of a life. And I'd like to give a pitch for Brian's old state, Maryland, where I grew up. They have one of the most developed, and actually Anita has worked there. She's very aware of it. One of the most developed peer support systems in the country. And that's a series of on our owns. Every county in Maryland has a nonprofit that is a mutual support center. And when people enter into a mutual support center, centers that are run by people who lived experience, they gain hope almost immediately. I can give 1,000 talks on hope, but there's no substitute for being in close contact on a day-to-day basis with people that are putting their lives back together. And a kind of a emotional AA is what we need. AA has done a reasonably good job for certain populations of people, but it's not good for people with severe psychiatric problems. It's not so good. But we have, through On Our Owns, which was based, by the way, for people that don't know it, on a book by Judy Chamberlain, On Our Own, which laid out 50 years ago, 40 years ago, the importance of mutual support. We don't necessarily want the same reimbursement structure either, by the way. We don't want to have to be reimbursed on an individual service basis, but more on a bundled, I don't know if you can't use the word bundled, on a not a cost reimbursement basis either, but a group of people who are receiving, and actually block grant funding is very good way because it's not restricted in the same fashion as CMS is. And we've worked for years to try to get CMS to relax some of their restrictions. They're still very medically oriented though, but either through general funds or through block grant funds or through bonds or some way to support places like On Our Own. In Massachusetts, they're called recovery learning communities. Excellent places. And they go and they start self-help groups all around the community. They have peer-run respites in the community. So I don't know, but the paradigm has to change in order to do that. For the funders, for the trainers, for the evaluators, and for the policy producers.
Yeah, and I think that thank you for highlighting Maryland. The On Our Own programs have been around for 30 years, so it's very nice. I want to make sure that the people on the call know that they can put their questions in the Q&A, and we'll pick up on them. I did want to go back to one of the questions that had to do with direct care. And you addressed it a little bit, but what do we do to help people in direct care? How do we, the workforce, especially in the direct care area, is decreasing. It's people don't want to work during COVID and face-to-face. They worry about their families, et cetera. Also, the big problem with direct care is poor compensation and lack of mobility. So any thoughts on how we incentivize more people wanting to work in direct care, and how do we improve the mobility for people in direct care to be able to move up and take on greater responsibility and be able to get greater pay? Anita, yeah, go ahead.
I've got a few thoughts on that. Yeah, so I mean, one of the things, there's several things that are really important when we think about what we might want to call burnout in that space. But one of the things that's really important is to help systems understand the whole context that the person works in. So it's not identified as a diagnosis or a depression or a problem that the person is having, rather it's a phenomenon that they're within. So we don't pathologize it unnecessarily. And why that's important is because systems, increasingly health systems, these larger health systems, and hopefully community mental health systems and other places are attending to their role in contributing and mitigating the kind of burnout that individuals can face. So that's just one element. The other element that I think is really important in our field is stigma. If we think of what we're doing, hopeless, if we think of what we're doing as not the stigma, and also the concept of recovery sort of added to that. If we think of what we're doing as, our role is not really making a difference. We're not, these, individuals don't have hope. They're not going to change. It's the fifth time so far this year that the same person has come back to the emergency room. That means our interventions aren't working. Changing that sort of paradigm or perspective or stance with the individual so that we're constantly reminding ourselves of the purpose. I think, purpose is really important, and a purpose it may be the fifth time that the person comes in that actually results in them being able to get the autonomy and the sense of hope that they can cling on to, like what Dan's talking about. But just because they've come back in doesn't mean it. We want to define that, or we want to sort of frame that as hopeful to the extent that we can, not that we're working with people that are in a cycle that they can't get out of. And I think in our field, reminding people of that is really important. And we may not do that enough because I've just seen so many different situations where that's kind of taken for granted. But reminding people of the keen purpose, that's one of our strategies, even within SAMHSA, where we're not involved directly in, grants management is one of our main things, but we try to do, I'm increasingly trying to do whatever I can to remind people of the purpose of the grants that we work with and the real difference that they're designed to make in individuals' lives. Me and the people who work in the field, and into that sense of purpose, I think that's what I'm really saying.
Anita, you're going in and out. You're frozen. Let me go to Kirsten. Do you have any thoughts on this, Kirsten?
Yeah, I mean, what your comments sort of reminded me that this is an issue we hear about a lot in the behavioral health field, that the reimbursement rates are not on par with reimbursement rates for similar services on the medical surgical side, just in terms of clinical services anyway. And, there have been studies and research done that highlights this disparity that we try to sort of highlight in the context of parity discussions, because I do think parity can be helpful here in thinking through some of this, and that those payer rates for some of these kinds of services really do affect the degree to which we can attract people into the field, particularly in some of the less credentialed areas. I think that Medicaid, there was this reminds me of a demonstration program that's ongoing right now within CMS, trying to think about, and it was established by Congress to try to address this issue of how do we build out more capacity to provide specifically substance use disorder treatment, and providing state Medicaid agencies with some funding. Again, state Medicaid agencies often don't have a lot of extra discretionary funding lying around to think about, and to use to do the work that's needed to really think about what are we reimbursing for this? How do we compare to other states? How do we compare to Medicare? How can we, think about these reimbursement rates, or in a way to really, start paying more for what's being provided and better reflect the value, and hopefully incentivize more providers into the program. One state example I always think of is Virginia, when they were really building out their substance use disorder treatment programs in recent times, and in light of the opioid crisis, greatly increased their rates for providers that met certain quality indicators, specifically, for example, methadone clinic providers, and saw a big increase in provider participation as a result. And so I think sometimes it's as simple as that, as providing the opportunity and the resources to really think about what's creating the problem here, where are the gaps. I would say the CMS demonstration I know about, part of it is doing an assessment. Where are the gaps in your state, across the different levels of care? How do you think about filling those gaps? I think really engaging with payer like Medicaid with regard to behavioral health is key. Certainly think the block grants can contribute there as well, but I think obviously engaging with Medicaid is important, as well as Medicare, on trying to fill some of these shortages. Thank you.
We had a question about responders. So I think this one's for you, Anita. What is SAMHSA's plan or thoughts regarding responders for crisis services? The mobile crisis in many states is by 911 by law enforcement. What is SAMHSA supporting in terms of alternatives to police responding?
Yeah, so thank you for that question. I think that's really important to kind of understand is right now there's a lot of different things happening. So we broadly frame three components to a crisis system. Someone to talk to, someone to respond in person, and a place to go. And you're talking about what we think of as the second service, which is someone to respond. And so who's on that team? At the moment, if you call the National Suicide Lifeline, National Suicide Prevention Lifeline, NSPL, or it's also known as the Lifeline, you talk to a person who's trained, and then that person, if they identify someone who's at imminent risk, they go immediately to 911. And 911 has three choices. Typically, there's some variability, but not that much. It's fairly standardized nationally. So three options. One is emergency medical services. The other is police or law enforcement. And the third is firemen. Some communities for mental health crises do send EMS, but others often send law enforcement. We'd like to change that paradigm so that increasingly 988, or what will become 988 from what now is the Lifeline, interacts much more directly with 911. And we can have alternatives to EMS or law enforcement where it's safe. The examples, as you're probably aware, around the country that have tried different models. One of the big unanswered questions, and we're actually helping to work with IMH on this, but one of the big unanswered questions is just exactly this question that we've been asked, and that is what component of responders is the right component? Do you need a common combination of individuals is licensed professional, like an LCSW, a social worker, together with a peer. That's a model that's fairly standard. Some models have paramedics who otherwise would be on the emergency medical response go together with peers and or licensed professionals. I was myself on a local, stayed on a place near the Chesapeake at the beginning of this week, and in a fairly rural part of the Delaware, Maryland, Virginia Peninsula called the Delmarva Peninsula. There's a little town there, a little community that was on the local news, and it just had announced that it's hired a social worker to pair up and ride along with its police department as a way to kind of answer some of the situation there. So my point there is there are various different combinations of these things, these kinds of responses that are happening. The good news is that most communities, or a lot of communities, are thinking about it. What we don't know yet, or what is the best combination, what's going to work the best to get at safe responses that work better for the individuals that we care about, those individuals with mental illness or who are having mental health and or addiction related crises. So that's a really important, an important and unanswered question is what combination of people work best, and where are they housed? Are they housed out of law enforcement? Are they housed out of emergency medical services? Are they deployed from a clinic setting? That'll probably look somewhat different in different communities, but from the parity perspective, we'd like there to be fairly, workable standards so that individuals, no matter where their crisis is, have reasonable expectations of what kind of response they're going to get. Similar to the way you would if you had, an auto accident and, you had an injured leg, let's just say, or knee, you'd have an EMS person who came, and we all have some standardized expectation of what the training is for what can happen in the field. We also know one of the things we've learned from several of these models that have been early adopters of alternatives to police, that for the most part, they can manage things really well, and we don't necessarily need law enforcement. I'm thinking of the Cahoots model, that I think their numbers are something like 90% of the time, 90 to 95% of the time, they don't need backup from police when they go, even with someone who's acutely distressed. They don't need weapons on site. They don't need the kind of show of force, so to speak, that an armed officer with their uniforms that are more or less designed to be intimidating. They don't need that. In fact, as many of us who've worked in emergency rooms know, that kind of presence can escalate things often. So I think we're learning, but we don't really know that we plan at SAMHSA to do as much as we can to look at those different models so we can have some answers for at least what works. There may not be one single answer for every community, but at least what are some models, and what are communities doing to develop those models, and also to our friend Kirsten, what are they doing to fund those models in a sustainable way? Because we will have, we anticipate some startup money from our shop, but what will we be able to do that's sustainable, that gives us a better way to respond, a better way to assist with individuals who are in crisis, to help initially, stabilize the emotions. Dan, I'm trying to think of your word, stabilize. We don't want to say stabilize maybe, but sort of help them through the emotional scenario so they can see more clearly what the next steps are.
Appreciate it. I want to say a word about, I think it's great to have a variety of models. The difficulty of the police is just what you were referring to. Police are trained to intimidate. I did a workshop several years ago with a police officer. He was from Bethlehem County, Pennsylvania. And before we even started, I said, I'm going to be talking about how we can communicate, more collaboratively, and someone's upset, you don't come in, too much force. And he said, everything about me designates force. The police car, the uniform, the stance that we're taught, the voice that we give, the weapon that we have. And I was like, oh my God, no wonder there's such a problem. I said, that scares people more. And then they don't follow directions, and then they get shot. And he said, well, that's our training. So not only do I think it'd be helpful to try to untrain or retrain, you know, as many police officers as possible, so if they are on a mental health situation, they do behave differently, but actually have the training in the academies be different. Because many of the instances that they're involved in involve unnecessary violence because of the fear and the fight and flight that people are in. They're already in fight and flight. And then if you increase that, just as you said, Anita, that's only going to make people more frightened, and they'll get angry and they'll fight back. So it,
Yeah.
I think the presence of a peer can be very, very helpful also, because it is hard to train police officers to connect in this fashion by themselves. And even some clinicians are taught sort of a little bit more, I'm in charge. But a peer at a time of crisis especially can be very, very helpful, as long as they're respected by the people that work with them and they're given adequate pay. In Massachusetts, we were just looking up what is a peer paid. It's really low, still really low. And in a state that's so expensive as Massachusetts, it's somewhere between $15 and $18 an hour, which maybe that's $30,000 a year. It's very, very low. And this is stressful work. So I think more funding, like parity, as Kirsten was saying, parity would be very important.
Thank you, Dan. And thank you, Anita. And I did want to make sure that the participants on the call knew that SAMHSA had their guidelines for behavioral health crisis care. The national guidelines, if you go to the SAMHSA website and you search for the national guidelines for behavioral health crisis care, you'll be able to find it. Now, I want to turn the call over to Vijay. He did have a question, so I think he wants to ask that question of the panel before we end our call. So Vijay.
Thanks. No, mine was a broader kind of question, because I really appreciated all the presentations and really all the information about how we're inching towards the future. And part, I guess, is maybe just my personal frustration in being in the field for as long as I've been. But there's part of me that feels like, maybe the way to go forward is this inching. But I think my question was that the universal experience that the entire population has undergone under COVID has really raised the salience of mental health issues for everyone, not just for people with serious mental illness. And I felt that this universal experience was an opportunity that we should all be capitalizing on to make a quantum jump for behavioral health. And so that at some level, it's nice to emphasize 988 and crisis services and maybe augment this service and that service. But it seems to me that somehow we need to be going back to, I think, something one of the panelists said, that the issue is really that advocacy is still an issue, and we're certainly getting more funding. But at some point, it's almost like we have to raise behavioral health to more of a national, if not international, priority level, like climate change. You cannot do, mental health is now some subset of health, and it's like 2% of the health, or I don't know, a small proportion of health. And so it always gets that minimalist attention because of the amount of funding it accounts for in health. And so at some level, it seems to me that some of the energy that we need to be expending is really to work on everybody's appreciation. I think there has been stigma reduction. I think even some of the experiences that we're hearing from sports people like Naomi Osaka and so on is just elevating this salience of health. And maybe we don't discuss it on this panel, but it seems to me in terms of the future, we should be somehow building on that kind of energy. I know we don't have a lot of time left, but if somebody wants to make a comment on that front, and maybe you know, we can discuss it later as well, but that was the thought. Anybody?
I agree. I agree.
I don't know.
Yeah.
Anyway, okay.
I-
Well,
I was gonna say I agree as well. And my question that I've asked before, sort of what maybe invite us to think about is what's our tipping point? Are we to a tipping point where we have, athletes, nationally known or internationally known athletes who talk about mental illness, NFL players that talk about bouts with mental illness and addiction
well,
as a part of their thing. Are we there?
my thought is, and maybe again, it's my mindset, that what has happened is that we go down very productive paths and we set up the rail tracks on that course. And then what happens is that with the change of administration or whatever, we don't build on those tracks. We go back and sometimes use those tracks and sometimes no, and start building a separate track. And so to me, the whole issue is, let's define a long-term vision and then let's do a total quality management thing where you plan, you do, you check, you essentially act again. But that's really where I was hoping some of this modeling, and maybe we can discuss this more in some of our subsequent sessions. I know we're 5 minutes away and I have a couple of announcements to make before I conclude. One is for those that are wanting CEUs, the codes that you need to use, let me repeat that, is NDBH, like National Dialogues of Behavioral Health, 12. So NDBH 12 is the code, and that's what you need to send Melanie Norwood at the address that we have given you with the evaluations that you should have received. If you haven't received the evaluations, then you can also request those from her. Second, I just want to underline the fact that please do the evaluations. We have a few more sessions and there may be things we can learn and adjust based on your experience, but you have to tell us what your experience was and your suggestions for some fixes. And so with that, Brian, I don't know if there's something you want to say or the panelists want to say, but I was actually just going to thank the panel and, thanks again for a very productive discussion for the future. And I hope you guys can join us again in subsequent sessions we will be having. For the rest of you that are on there, thank you for attending. Please get the word out as much as you can. And we have our next session again next Thursday, starting at 2 o'clock Eastern time. And the focus will be on some of the things we were talking about today, like the 988 line and how it's being implemented in much greater detail and depth. So thank you again. Thank you, Brian, for doing a fabulous job sort of moderating.